Good morning. My name is Ângela Mira, and I'm a family physician working in Baixo Alentejo, a rural region in southern Portugal. Every day, I witness how social factors shape the health of older adults, often more than any medical conditions. Today, I want to share with you how loneliness, an invisible but powerful force, influences healthcare use in this population. To begin, let me briefly frame why loneliness matters. Loneliness is increasingly recognized as a global public healthcare challenge. It is not the same as social isolation. It is a subjective emotional experience, often hidden from clinicians. It is strongly associated with depression, cognitive decline, multimorbidity, and even mortality. Because of this, loneliness is now considered a new geriatric giant, and rural regions like mine face amplified risk due to depopulation and weakened social networks. With this context in mind, let me explain why this study was particularly relevant in our region. Baixo Alentejo is one of the oldest and most sparsely populated regions in Portugal. Geographic isolation, low density, and socioeconomic vulnerability create fertile ground for loneliness. Clinically, we often see older adults seeking healthcare not because of medical needs, but because they lack social support. This leads to increased service use and sometimes iatrogenesis. Given this reality, we wanted to understand the phenomenon more systematically. So let me show you what we aim to investigate. Our aim was straightforward to examine whether loneliness is associated with increased healthcare utilization among older adults in a rural Portuguese region. To answer this question, we designed a study that I'll describe next. Was a cross-sectional study involving community dwelling adults aged 65 and older. Participants were randomly selected from primary care records. Data collection took place between March and August 2024. The study was conducted in Baixo Alentejo, a region with rapidly aging population. Now, let me show you the instruments used to measure loneliness and related variables. We used the UCLA Loneliness Scale, a validated tool widely used in research. We also collected socio-demographic data, family function using the Apgar scale, and depressive symptoms using the PHQ-9. Healthcare utilization was measured through primary care visits, emergency visits, and daily medications. With the methodology established, let's look at who participated in the study. Our sample included 318 older adults with a mean age of 75.5 years. Most were women, and nearly one-third lived alone. Low income and low schooling were highly prevalent. Interestingly, neighborhood relations were strong, a characteristic features of a rural community. Now that we know the population, let's explore how common loneliness actually was. Loneliness was highly prevalent. More than half of participants reported mild loneliness, and nearly 15% reported severe loneliness. When adjusted to census data, these numbers rise even further. This means that loneliness affects the majority of older adults in this region, a striking finding. But what does this mean for healthcare use? That's what we examine next. We found strong associations between loneliness and healthcare utilization. Severely lonely individuals had significantly more primary care visits, more emergency visits, and higher levels of polypharmacy. These associations remained significant even after adjusting to comorbidities. So, how should we interpret these findings? Let's move to that. These results reinforce what many clinicians observe. Lonely individuals often seek healthcare for emotional research. Medical visits become a substitute for social connection. This can lead to overdiagnosis, overtreatment, and increased healthcare costs. Loneliness is therefore not only a social issue, it's a clinical risk factor. To understand it better, we also looked at what predicts loneliness. Depression emerged as the strongest predictor, followed by poor perceived health and family dysfunction. Urinary tract disease also appeared as a determinant, possibly reflecting chronic discomfort or mobility limitations. On the positive side, strong neighborhood relationships were protective. These finds make even more sense when we consider the rural context. In rural areas, neighbors often play a central role in social support. Living alone does not necessarily mean being lonely. What matters is the quality of relationships. Baixo Alentejo reflects broader European trends, aging populations, depopulation, and social vulnerability. Given this, what should clinicians do? Loneliness should be treated as a clinical risk factor, just like hypertension or diabetes. Primary care teams should routinely screen for loneliness. We must learn to identify social diagnoses and avoid medicalizing social suffering. But addressing loneliness requires more than clinical action. It requires system level change. Social prescribing, community programs, improved transportation, and intergenerational initiatives all play a role. Policies must align with the WHO's Health in All Policies approach, recognizing that health is shaped by social environments. And of course, prevention must start early. Loneliness, it's not just an issue of old age. It accumulates across the life course. Building social resilience early, promoting community engagement, and preparing individuals for aging transitions can reduce the risk of loneliness later in life. Before concluding, let me briefly acknowledge the study's limitations. This study has limitation. Its cross-sectional design prevents cause inference. Some variables rely on self-report, and the sample includes only primary care users. Still, the associations observed are strong and consistent with international evidence. With that in mind, let me summarize the key conclusions. Loneliness is a measurable and clinically relevant determinant of health. It's strongly associated with increased healthcare utilization. Addressing loneliness requires integrated medical and social responses, and prevention is essential across the life course. I want to leave you with the final message. Loneliness is not just a social issue, it is a determinant of health. Recognizing and addressing it is one of the most important challenges in caring for aging populations. Thank you very much for your attention. I'm happy to discuss the study further or answer any questions.